The opinions expressed in the following program are not necessarily those of Eastlink Community TV, its sponsors, or partners.
Good evening, everyone, and welcome to Science North in our beautiful Valley Cavern. My name is Amy Henson. Bonjour, bienvenue, Ani Tanshi. I have the pleasure of being your host for tonight's MEDTalk event, and I am the senior scientist here at Science North, leading some really wonderful teams in science and the exciting exhibits and things that you see on the floors every day. C'est mon plaisir de travailler avec une équipe de scientifiques incroyable pour créer des expériences de science exceptionnelles ici à Science Nord. We are so thrilled to have you all here this evening for a very special presentation. And we have Eastlink at the back who is recording tonight's presentation, and we will have audiences from all over Canada joining us tonight. Thank you also to Christina Forsyth and Beth Irvin for providing American Sign Language interpretation for tonight's presentations. I'm honored in welcoming you today and recognizing the place that we stand on. It is my privilege to learn and work on the ancestral lands of the Atikameksheng, Anishinaabe, and Wanapate First Nation. As a settler and Métis woman, I've had the honor to work and live alongside many Indigenous peoples from across the Robinson-Huron Treaty, the Robinson-Superior Treaty, and many members of unceded territories, and as well my Métis brothers and sisters. I give thanks for all the knowledge that I have been given from our Indigenous peoples, and that knowledge has been shared with me. And what I love about the knowledge that I have learned is the interconnectedness of First Nations understanding and Indigenous knowledge understanding of the world around us and how all of that is interconnected together, and the importance of the scientific rigor as well of Indigenous knowledge. It has been a pleasure for them to help me know and understand a little bit more about science in the world around us, including our interconnectedness to our human health. For our audiences watching across Turtle Island, we also give thanks and honor the recognition of the land each and every one of you are on Indigenous land today. So we're here for MEDTalks, and Northern MEDTalks has a wonderful history here. This is our fourth MEDTalks event here at Science North. Each presenter for MEDTalks has 10 minutes to share their experiences and story. We'll begin the evening with 5 presentations, and then we're gonna follow by a 20-minute intermission, and then the final 5 presentations will come after that. For our in-person audiences, in that intermission time, you're welcome to mingle, chat with the presenters who have gone before, talk about some of the interesting things you may have learned, and there are refreshments here as well. For our online audience, there will be some interesting MEDTalk performances from years past. So we'll have 2 MEDTalks from our 2022 with Dr. Sean Sullivan and 2023 performances with Dr. Roxana Riggi that you'll enjoy. We've had MEDTalks, amazing MEDTalks for many, many years. So the key to MEDTalks, though, is there are no questions. So we're not going to be taking questions in between. We're going to keep this rolling, which makes this event exciting and fun, and I know you will all enjoy it. So I'm sure every one of you has seen TED Talks before, probably online, or listened to talks, and this is what this event is inspired by. What makes this event really unique is the Northern Ontario connection that we have. Each of our presenters here tonight is partnered with Laurentian University's Science Communication graduate students. And each of those students have helped the presenter craft an incredible story that you are going to listen to tonight. And there's also, with the Science Communication students, a team who have worked behind the scenes to make all the magic that you see here tonight happen, which I'm always very excited about. Our science communication students are a really important part of our family here at Science North. We partner with Laurentian University to provide a really amazing learning opportunity where they get to live in situ with us here at Science North and learn science communication while learning all the important theory background and get hands-on experiences through the Laurentian University Science Communication program. I really want to give all of our students, though, and all the work that each of our presenters, before we start, I really hope that you'll give them a round of applause. Thank you. So after tonight, we're gonna hang out here in the Valet Cavern. There's refreshments in the back, and this is a great time that you can come and just talk to some of our presenters, discuss some of the topics that you may have learned, and we really hope that you'll take a good look at some of the connections to our community and those health connections, maybe to yourself, to somebody that you know, or in our broader scope of our community a little bit longer. So our speakers will be hanging out here for a little bit afterwards, and they'll be more than happy to chat with you then. We also are really interested in hearing about this event tonight. So if you have anything that you want to learn about the science communication students' experiences as well, they will also be here, and they would love to get your feedback and talk to you a little bit more about their experiences in our graduate program. So I know, and it happens every year during MEDTalks, you're going to hear something incredibly inspiring tonight. And at Science North, it's our mission to inspire the next generation of scientists, of engineers, of medical professionals to really engage with science now so that they can support our communities in the future. It's important that we have this mission in hopes that our next generation will be the great scientists of our community and leaders in our community as we move forward. So tonight's event is also supporting a fund that's near and dear to my heart called Science North's Science for All Fund. It's an innovative fund that provides access for people in our community who may not be able to have access to all of our wonderful science, technology, engineering, and math programming. I have had the opportunity to experience firsthand what it means to people to come here to Science North and maybe even visit for the very first time and experience science in a way that they never imagined when maybe they wouldn't be able to otherwise. And so we're hoping that you'll be in supporting us tonight in this fund. You can do so by scanning the QR code behind me. There is also a donation box at the front desk or front entrance when you are coming in the door. And as well, you can always visit our website online at sciencenorth.ca. All donations are incredibly appreciated, and we hope that you will join us in making sure that science is always for all. So, without further ado, we are about to go on a journey. It's a journey of amazing stories that are engaging, inspiring, and most importantly, grounded in all the great work that is happening in Northern Ontario in our hospitals, clinics, research labs, and advocacy groups. We hope that you learn something new about your own health and how you are connected to the world around you. And of course, we want to make sure to inspire all of you to take care of your health and to learn more every single day. So without further ado, let's hear from our very first presenter.
Our first speakers of the evening are Kaylee Voutier and Nicole Sage from Crohn's and Colitis Canada. The number of Canadians being diagnosed with Crohn's disease and ulcerative colitis continue to rise every year. After her diagnosis, Kaylee learned firsthand that increasing access to support and decreasing stigma begins with a conversation. Join her and Nicole as they walk us through a patient's journey. Welcome.
I invite you to come along for the ride with me as I visit my doctor to discuss my recent test results.
Thank you for coming in today, Kaylee. So I'd like to talk to you about your recent colonoscopy results. So we found ulcers and inflammation in the lining of your rectum, and the official diagnosis is proctitis, which is a complication of inflammatory bowel disease. So I'm going to prescribe to you cortifoam, which should help, but the inflammation could come back.
Okay. So it's not the juvenile polyps or the internal hemorrhoid that she thought it might be before the scope. It's proctitis. Did I ever learn about that in biology class? No. But the medication should help. But it can come back. So the medication can make it go away? How did I even get this? I've never had something like this. I don't think anyone in my family has this. Am I going to be okay?
Okay?
Okay. Hi, my name is Kaylee, and these are all questions I had after receiving my diagnosis of ulcerative colitis over 10 years ago. I didn't know what IBD is. I didn't understand that this is a chronic illness. I had to educate for myself and advocate for myself.
Hi, and my name's Nicole, and Kaylee and I are going to be talking about poop. So we hope you're ready.
So for myself, it started off as mucus in the stool and then changed to blood in the stool. Because it started as inflammation of the rectum, I didn't see too many symptoms. It wasn't until in 2016, when I had my flare-up of colitis, that I saw other symptoms.
So some of the most common symptoms of inflammatory bowel disease, IBD, can include abdominal pain and cramping, diarrhea, rectal bleeding, weight loss, nausea, and vomiting. Healthcare professionals use a combination of tests in order to diagnose IBD. So these can include blood tests, stool tests, scopes, and other imaging techniques.
Imagine running to the bathroom 20 times a day, in pain, looking normal, and you don't know what's wrong, and you have to wait 6 months or longer to find out. But everyone's story is different.
So IBD describes a group of conditions, and the two main forms are Crohn's disease and ulcerative colitis. So Crohn's disease is anywhere in our gastrointestinal tract, from our gum to our bum. Ulcerative colitis affects the colon, the large intestine, including the rectum and the anus. So these are lifelong diseases that inflame the lining of our gastrointestinal tract, and there is no cure. And the causes of IBD are complex, and they're influenced by multiple factors. It's believed to involve a genetic tendency or predisposition and a trigger in the environment that are combined to set off inflammation in the gut. And this is still being researched today.
Examples of these risk factors include being a current or former smoker, air pollution, hormone drugs, stress and depression, and of course genetics. But for me, there's actually a lack of a genetic component, so I don't know how or why I got IBD.
Canada has one of the highest rates of Crohn's and colitis in the world, with over 322,000 Canadians affected. In Canada, IBD prevalence is higher among the Ashkenazi Jewish, South Asian immigrants, and the Indigenous population. Someone new in Canada is diagnosed with Crohn's or colitis every 48 minutes. So to put that into perspective, that means 5 people are going to be diagnosed during our time here tonight.
So in 2016, my colitis flared up. It happened throughout the year, and I tried treating it with suppositories that I was prescribed. I even went on a big East Coast trip with my family where we camped a lot along the way, and every night I was in the bathroom stall of a campground bathroom giving myself a suppository. But you probably couldn't tell that I was sick. In the fall, it got worse, and I ended up in the hospital. I was having bloody bowel movements, weight loss, energy loss, and my mental health was affected, just to name a few of the symptoms. My entire colon was now inflamed. I ended up on a biologic drug, which I still receive through an IV infusion every 6 weeks. IBD is often considered to be an invisible illness because patients can look healthy, just like I did during my trip.
Studies show that stress, anxiety, and depression may trigger IBD symptoms and vice versa.
So just like in all chronic illnesses, support systems are a very important part of IBD. This is something you live with constantly, so you need people who understand the physical and mental health impacts. I have a great support system of my boyfriend, my parents, and my brother. And while I have the experience of needing a support system, Nicole has the experience of being a support system.
So growing up, I watched my mother navigate her Crohn's disease and ulcerative colitis. She was often in pain, always in the bathroom, and seemingly depressed most of my life. She missed a lot of really important milestones, like my high school graduation, my senior prom. Then years later, my father was diagnosed with ulcerative colitis, and days ago, my brother was diagnosed with Crohn's disease. So I have witnessed these diseases and their impact firsthand. And so my advice to you is to listen to your loved one when they say something is not right, and educate yourself about IBD. Speaking of education, now I'm a staff partner with Crohn's and Colitis Canada, which offers an array of supports and services to help those living with IBD and their loved ones. We have exciting research projects. We have free apps like our Go Here Washroom Locator app and our My Gut System Tracker. We have IBD scholarships, Camp Got to Go, which gives kids and teens who have Crohn's or colitis a really fun camp experience, and an online peer support community platform. Visit crohnsandcolitis.ca to learn more.
In 2017, I started volunteering with Crohn's and Colitis Canada because I finally felt that I understood the challenges of IBD and how scary it can be. In 2023, I became the Sudbury Chair for the Gutsy Walk, which is an annual fundraising walk that raises money and awareness for Crohn's and colitis. I later became the Sudbury Chapter President. Through these roles, I get to share my story and help others.
If there is one thing you take away with you tonight, please start having meaningful conversations about IBD. Be a champion. Lend your voice. Let all of those affected by IBD know they're not alone.
My journey has led me here to the stage, comfortable to talk about all of this with you. I used to whisper words like rectum and anus, but over time I have become the person I am today, comfortable talking about IBD, and I hope that others feel the same. These conversations may be uncomfortable, but the more we talk about IBD, the more we decrease the stigma surrounding it.
And we'd be happy to start these conversations here with you tonight. So you can find Kaylee and I at intermission or after the show. So let's talk about guts.
We now welcome Dr. August Pierik, an anesthesia resident at the Northern Ontario School of Medicine University. When a patient undergoes surgery, they put their full trust in their anesthesiologist to ensure the procedure is smooth and painless. However, few people truly understand all the work that goes into keeping them comfortable in the operating room. Dr. Pierik is here to help us understand the science of anesthesia and dispel common misconceptions by taking us through a patient's experience during surgery. Bienvenue.
Hi, thank you so much for having me. So I'm August. I'm a resident doctor with anesthesia at Nossum University, and I'm very happy to be talking with you tonight about one of my favorite topics, which is anesthesia. It's a topic I think we all have some awareness about, but because most of our experience with anesthesiologists involve our loss of consciousness fairly early on, I think our knowledge about anesthesiology remains somewhat limited. So I want to walk you through a general anesthetic while teaching you general things I think everyone should know about anesthesia. So first of all, I introduced myself as an anesthesia resident. So what exactly does that mean? Well, a resident is a medical doctor who's graduated from medical school and is working under the supervision of another doctor who's completed their medical training. And all medical doctors do residencies. Anesthesia residency is 5 years in Canada to work at a hospital the size of Health Sciences North. And the terms anesthesia and anesthesiology are interchangeable, same with anesthetist or anesthesiologist. The dictionary definition of anesthesia is insensitivity to pain artificially induced by administration of gases or injection of drugs during surgery. But I want to paint a clearer picture of what exactly anesthesiology is. So my goal is that you leave here with a better understanding of what anesthesiologists are and who we are and what it is that we do. So in order to do that, I'm going to tell you a story as if you were a patient coming for surgery, and we'll journey through you having your surgery focusing on the anesthetic, from the falling asleep to the waking up. My biased disclosure here is that if I was a surgeon, the story would be about you going through your surgery with the focus on the surgery itself, the cutting, the removal of the problem, the suturing, and the anesthetic would maybe get a quick mention at the start. But I'm an anesthetist, and so I will give a quick mention to the actual surgery, and I'll focus on my side of the things, which is the anesthetic. So usually when you're coming for surgery, there's a body part with a problem. I'm going to just make up an example here that your arm is broken, so you're coming for surgery for a broken arm. And the surgery is going to require a general anesthetic. And this is what most people think of when they imagine going to sleep for surgery. Total, complete unconsciousness, no awareness, no pain. And a lot of our jobs as anesthesiologists involve giving patients general anesthetics for surgery, but it's actually not all that we do. When we're not giving general anesthetics in the OR, you can find us treating acute pain, chronic pain, seeing patients in clinic before their surgery. Some of us work in intensive care units, and sometimes you can find us in emergency departments managing airway emergencies. So I want you to think of a general anesthetic like a flight, and an anesthetist like a pilot. A pilot's job is to get you safely from A to B. An anesthetist's job is to get you safely through a surgery. So taking off for a flight is like induction of anesthesia, which is the term we use for going off to sleep for a surgery. Cruising at altitude on a flight for a pilot is like what we call the maintenance phase of an anesthetic. So this is the part when the surgery bit is actually happening. And just like a flight, it's not always smooth sailing. Sometimes there is some turbulence, and we have to be able to adapt and manage any emergencies as they happen. And then landing the plane at the end of the flight is like emergence, which is the term we use for waking up or regaining consciousness after surgery. So you've come to the OR on the day of your surgery, and the first thing you might notice is just how many people are in the room. And we're all here actually for the same reason. The surgeon, the anesthetist, OR nurses, the staff who bring you to the room, the staff who clean the ORs. We all work very closely with each other every day in order to get you through a successful, safe surgery. So once you're in the OR, before you actually go to sleep, we do our pre-flight safety checklist, or surgical safety checklist. So we make sure that we're all on the same page in regards to what surgery you're having, what side, make sure it's the correct arm, your allergies, medical history, and then the surgical and anesthetic plan. And this reduces errors and reduces your surgical risk. You'll get an IV, that's where medications and fluids go through during the surgery. And then you'll get medications while you breathe oxygen to get you off to sleep. And we tend to use a combination of medications that reduce pain and awareness, as well as a paralytic after you're unconscious. And the sleep that we induce for a general anesthetic is not the same type of sleep as you experience at night. When we induce anesthesia, your breathing stops until we take over and start breathing for you. And this is why I think it's important that you know that anesthetists are doctors. There's certain ABCs that you need to stay alive, and this is airway, breathing, and circulation. So air needs to go in and out, blood needs to go around and round. And anesthetists are doctors who tightly control all three of the ABCs for you to keep you safe while at the same time deeply unconscious enough for surgery. So once we've induced anesthesia to control the airway and breathing, we'll put in a breathing tube, and this is called intubation. We lift your jaw with a laryngoscope, which is pictured here, and we put a breathing tube into your airway. And the end of the breathing tube sits above both lungs, and it's connected to a ventilator that will give you the right amount of oxygenated air. Without airway and breathing, you'd quickly lose C, which is circulation. Your heart needs oxygen in order to do its job, so getting control of the airway and breathing is a key part of the anesthetist's job and can be a higher risk part of the operative period. So now that you're induced, we're in the maintenance phase, so you're going to get a gas anesthetic delivered through a ventilator, and the gas that we use currently is called sevoflurane. And it works on multiple receptors in your brain, reducing transmission of the brain's messaging signals, keeping you unconscious. As far as monitoring goes, we'll watch the electrical activity of your heart, your blood pressure, oxygen levels, and temperature. We're vigilant to note any changes, and these signals let us know how much pain medication to use and when we need to step in to support. And support is sometimes necessary because anesthetic drugs, as well as surgery itself, affects the body's normal functioning. So we use medications to keep blood pressure, heart rate normal, and we adjust our ventilator to keep your oxygen levels normal as well. So there's two common fears that people have when it comes to anesthesia. One is the fear of waking up in the middle of surgery. I'm here to tell you today that you will stay asleep during your general anesthetic for a few reasons. First of all, I will watch you closely. I won't leave you unattended to go on a coffee break. And these monitors watch you very closely too. So the second thing is, long before you start waking up, in the sense that you have any awareness, your blood pressure rises and your heart rate goes up. And if that starts to happen during the surgery, your anesthetic is deepened with more medications. And the last thing, that it actually takes a long time at the end of surgery to get all the drugs out of your system for you to wake up. So you need to breathe out the gas, blood levels of your IV anesthetic need to drop before you can achieve consciousness again. So waking up is a process. It doesn't just happen suddenly during surgery. And the second common fear that people have is not waking up at the end of surgery. So anesthetics, like air travel, do have associated risks. Your risk of dying during the perioperative period, meaning the time of your operation to 1 month after, it's higher than your risk of being in a plane crash. Like air travel, over the last 100 years, anesthesia and surgical safety have increased due to improved technology and safety processes. Unlike air travel, where you can reduce your risk to zero by just staying home, not having surgery when surgery is indicated has its own risks. So the decision about surgical risk versus potential reward is made with you and with the support of your medical team. And the good news is that you do have some control over your surgical and anesthetic risk. So the healthier you can be, the more you can lower your anesthetic risk. So eating well, exercising, not smoking, avoiding alcohol and other drugs, should you ever need a surgery, your risk will be lower. So now it's time to wake up. We're going to reverse your paralysis. We check your muscle strength with a nerve stimulator to make sure you're strong enough. We make sure that you have enough pain medication on board so that you can wake up comfortably. And then when you've breathed out enough gas and blood levels of your IV anesthetic drugs are low enough, you start breathing on your own again, and we can take out the breathing tube before you're even fully awake. Most people are still not awake enough to be aware of the breathing tube coming out in the operating room. And all good general anesthetics end with a popsicle in the recovery room. This is where most people actually remember waking up. And we have a very good team of recovery staff who will take care of you and make sure you're ready to go home or to the medical floor to recover. So that's a general anesthetic with some general things I hope you've learned about anesthesia. First of all, anesthetists are doctors. You will stay asleep during your surgery. Anesthetic risk has greatly decreased in the last 100 years, and you have some control of your anesthetic risk, and you can control it by making good choices in regards to your health. Thank you.
Up next, we will hear from Ginette Demers, a registered social worker currently working as the Manager of Health Equity at Public Health Sudbury and Districts. Our health outcomes are not only shaped by physical conditions, but also by social and economic factors. Ginette will explore how these social determinants of health can lead to people experiencing uneven access to healthcare. Please be advised that this next presentation may be triggering for some audience members, as there will be dealing with topics related to childhood trauma and violence. Ginette will emphasize that we all have a role to play in promoting health equity as community members. Welcome.
Good evening. Most of our life's experiences are not coincidental. People such as our friends, family, coworkers, and circumstances like our social class, our education, our gender, where we're born, and so forth, really have some influence over the trajectory of our lives. Influencers, on the other hand, hold a lot of clout. They can inspire or guide our actions and those of others. What if each one of us had the power to shed light on, to influence and challenge even a little bit the conditions that make us well and healthy? Imagine the difference this would make to our world and our societies. We're all inundated with news about how it's becoming increasingly difficult to access a healthcare provider when we need them most. Not just about care, health is also about promoting healthy behaviors, supporting healthy environments, and advocating for policies and funding that help ensure everyone has opportunities for health. What if people and conditions made it possible for us to avoid needing health care unless it was absolutely urgent? What difference would that make on our well-being and on the healthcare system as we know it today? In my social work practice, I've met lots of people who have struggled just to survive. Earlier in my career, I typically focused on attending to people's behaviors and on developing support plans to help them in overcoming challenges, or at the very least, to alleviate some of their hardships. I want to tell you a little bit about a 19-year-old woman I first met in a shelter. We'll call her Jessica. Jessica came to me expressing a desire to change her situation. On the surface, it appeared she was struggling with her breathing and experiencing anxiety and depression. She could have easily presented this way to any other healthcare professional. I think hearing parts of Jessica's story can help us consider how, if we scratch beneath the surface and explore some of the underlying causes for ill health, we may realize our experiences are in fact influenced in large part by our status, our living conditions, and the opportunities we have. Jessica and her little sister were raised by their mom. As a single parent, Jessica's mother tried to make ends meet by working 2 jobs. Without family or caregiver support, Jessica's mom was forced to leave Jessica at home alone a lot of the time to care for her younger sibling. The day she turned 11, Jessica was making supper while her mom was at work. She left a big pot of boiling soup on the stovetop and turned her back for just a moment. Within seconds, her little sister, eager to help, stepped onto a stool to stir the soup. Within moments, she stumbled and the pot of soup fell onto her. Jessica ran down the hall asking a neighbor for help. They called 911. It was a tragic accident, resulting in severe burns to the child's hands and belly. Nobody was at fault. However, the doctor had to call Children's Aid as they couldn't reach the parents. Later that week, due to perceived neglect and inadequate supervision, both children were removed from their mother's care and placed in different foster homes. While in care, Jessica was often neglected and verbally abused. One of her foster dads had an alcohol use disorder and often broke things and shouted all of the time. Jessica was frightened there. What kept her spirits up was knowing that every couple of weeks she'd get to visit with her mom and her little sister, and that one day they might be back together soon. At the age of 12, Jessica was diagnosed with a learning disability. By then, her grades were suffering and she was being bullied at school. Despite having been identified with a disability, Jessica did not receive specialized support or adequate care in the classroom or at home. Sadly, Jessica's mom died in a tragic car accident just after she turned 13. After the funeral, she didn't get to see her little sister anymore. The pair lost contact when Jessica's adoptive parents moved out into a new community. In the next couple of years, attending school became increasingly more difficult. Jessica found herself drawn to a crowd of older youth, and she stopped going to classes altogether. Her adoptive parents tried to help, but she shut them out. She would lie, fight with her younger adoptive sister, and sneak out of the house a lot. At 17, she was kicked out for having gotten into a physical altercation with her younger adoptive sister, this one resulting in physical injuries. So after that, she couch surfed a while and eventually moved in with her much older boyfriend, Mike. Mike drank a lot and cheated on Jessica multiple times. When she confronted him, he became angry. He would say things like, nobody else will want to be with you, and you're so stupid. He was very possessive and controlling, often not allowing her to leave the apartment without him. Jessica felt completely alone and had nobody to turn to for support. She wanted to get her own place, but she didn't have enough money. She learned she couldn't qualify for subsidized housing unless she was homeless or living in a shelter. And she was told there was a long wait list to get into subsidized housing. Determined to make her life better, she got a job in housekeeping at a local hotel. She liked this job. She was good at it. Unfortunately, she was late a lot, missed some shifts due to having anxiety and panic attacks, to the point she would often black out. And she wanted to tell her boss about what was happening, but all they did was yell and threaten to fire her. She told herself she would do better. She really needed to keep this job. About 6 months later, Jessica had been written up 2 times, was feeling quite nervous about what would happen next. She just continued to persevere, but it became increasingly difficult, especially at home. Just when she thought she might have saved enough money to get her own place, Mike demanded she give him her paychecks. Jessica refused. He became violent and assaulted her. A neighbor called police, Jessica was brought to the hospital, and Mike was charged. While there, she learned she'd been pregnant, and the physical assault caused her to have a miscarriage. Jessica was devastated by yet another loss. She stopped working and became further isolated and depressed. Mike had been charged and evicted, and now she had nowhere to go. Her circumstances forced her to take refuge in a shelter for abused women. To cope with her anxiety, she secretly drank in her room. Her health declined. She began experiencing fainting spells and had lots of headaches. During one of those episodes, staff were concerned, and so they called an ambulance. While at the ER, Jessica was quickly assessed and told nothing was wrong. She'd be better once she sobered up. After spending nearly 5 months in the shelter, staff advised Jessica she'd need to start making plans to transition back into the community. Jessica pleaded for a 1-month extension. By then, her health hadn't gotten any better. She needed a new prescription filled, but her wallet had been stolen. She had no money, no ID, was feeling quite desperate. Although she really enjoyed cooking her whole life, most days she didn't have energy to help prepare meals at the shelter. She just wanted to sleep and escape. At her lowest, she advised staff that she wanted her life to end. Once again, an ambulance was called. Jessica returned to the hospital. Later that night, she called staff to advise she'd been admitted to the inpatient psychiatry unit. I don't know what happened to Jessica after that. We often think of biology, genetics, behaviors, and lifestyle choices as the main drivers of health, but really, our health is largely determined by socially constructed factors, also known as the social determinants of health. These include income, education, ethnicity, access to support networks, and so forth, recognized as the best predictors of human health and well-being. Public health works with community partners in taking action to address these factors. In public health, we also consider the structural determinants of health. These have been described as the written and unwritten rules that drive patterns of advantage and disadvantage among different groups, creating differences, inequities. We call these health inequities. The differences are really about ensuring everyone has access to health and well-being. Unfortunately, the rules that I just spoke of, they're typically created by those who have more power in society, so it's no surprise they're designed to maintain the status quo. Social, political, and economic factors shape the conditions of daily life. They create the circumstances in which we are born, work, grow up, live and love, and eventually age. These circumstances determine whether we need to visit a doctor, a clinic, or a hospital in the first place. Through Jessica's story, we can see how past and current life circumstances can profoundly impact health and well-being. Determinants of health do not operate in isolation. They're interconnected. To achieve health equity, we need to understand how and why certain conditions are impacting people's ability to be healthy and take those into account when developing and designing policies, programs, and services. Looking at the image of this tree, we can see many factors contributed to Jessica's health conditions. The leaves represent the challenges Jessica experienced. The roots represent the social conditions leading to her compromised health and well-being. The soil represents the powerful structures that underpin the social conditions contributing to unfair outcomes. My apologies. In this case, the structural determinants include a lack of resources within the education system, social policies that prescribe certain rules, discriminatory employment practices, biased attitudes in healthcare, social exclusion, gender-based violence, and more. The circumstances leading to poor health for Jessica were, in a sense, designed as a result of her social and economic conditions. Health inequities are systematic, socially produced, unjust, and avoidable. In Jessica's case, her learning disability, anxiety and depression, and dependency to alcohol were socially produced by her traumatic childhood, her experiences of grief and loss, violence and lack of security, limited education, and few social supports. And they were also avoidable through increased access to family support, childcare, living wages and food security, affordable housing, education, employment, and training opportunities, and a supportive, inclusive community. You probably noticed there were many influencers in Jessica's life. Interactions with each of them impacted her life's path in some way. There are many Jessicas out there with many challenging trajectories. I'm sure no one would disagree. Everyone should have the opportunity to live a long, healthy life. Together, we can change the structures in ways that increase beneficial connections, improve equity, and promote better futures for all. Healthcare alone cannot fix our problems. Everyone, teachers, counselors, employers, neighbors, nurses, politicians, coaches, you and I, can start a conversation about health and not talk about healthcare at all. Each of us has power. We inform and exist within structures we're collectively responsible for. Inequities in health are the direct result of decisions we all make. We can make decisions differently for the health and well-being of our communities. Each of us in our own spheres can challenge the status quo. How will you use your influence? Thank you.
Next, we will hear from Dr. Thomas Edwards, an exercise researcher and medical student at Northern Ontario School of Medicine University. Approximately 10% of Canadians are living with a mobility disability, a number which will only increase as our population ages. The benefits of exercise training are well known, yet people with these disabilities face tremendous barriers when adopting exercise into their daily routines. Dr. Edwards will talk about the benefits of adapted exercise equipment and how we can help reduce barriers to participation. Bienvenue.
So with a show of hands, how many people here exercise or try and be physically active? Okay, good. I'm seeing lots of hands. I like to see that. Now, if I were to ask you to envision or picture exercise, what does that look like to you? Maybe running, lifting weights, swimming, cycling, yoga. These are all great examples of what exercise can look like. Now, how would your vision of exercise change if you were in a wheelchair? I'm sure for many of you, the idea of exercise changes drastically. And for some, the idea of exercise in a wheelchair may even seem impossible. Well, hopefully after our conversation tonight, you will all leave here rethinking exercise. So during my PhD, my research primarily focused on adapting exercise for those with physical disability, specifically those who use wheelchairs. And that may seem like a very specific area of research, and to be fair, it kind of is. But what if I were to tell you that according to the latest Statistics Canada census, over 4 million Canadians, or 1 in 10 Canadians, are living with a physical disability, meaning they experience significant impairments that affects their ability to walk. It's also important to note that number is expected to increase as Canada's population ages. And unfortunately, over time, disability accumulates and often gets worse, and rehabilitation strategies like exercise training start to play a more important role in the disease management process. So, you might be asking yourself, well, what exactly are the benefits of exercise? Why should someone in a wheelchair even bother? Well, to answer that question, we can look at the research. From a physical perspective, exercise can improve strength, flexibility, and cardiovascular health, all of which help improve mobility and promote independence. And the benefits aren't just physical. Exercise offers significant emotional and mental health benefits and has been shown to reduce stress, anxiety, and depression, all of which contribute to improved quality of life. Exercise can also offer a sense of empowerment or self-confidence, while also providing valuable social opportunities, which are crucial for mental and emotional health. So in short, exercise provides numerous benefits for those with physical disability. So your next question might be, is it safe? How can someone in a wheelchair safely exercise? Well, again, to answer this question, we can look at the research. A report published by the US Department of Health and Human Services concluded that exercise participation for people with physical disabilities was, in fact, safe. And not only was exercise safe, but the benefits far outweighed the risks. And since this report, even more research studies have reinforced the notion that exercise is safe for people with physical disability, like those with multiple sclerosis, muscular dystrophy, those recovering from stroke or living with spinal cord injury, among various other conditions that cause physical disability. Now, earlier, I asked you to envision what exercise might look like for someone in a wheelchair. And what I would like to do now is spend some time showing some of the amazing adapted exercise equipment that I have had the opportunity to research and leave you all with a better idea of what exercise might look like for someone with physical disability. So the first piece of equipment I want to talk about is called an arm cycle ergometer. And this is one of the most commonly used adapted exercise equipment. With this piece of equipment, an individual is able to exercise from a seated position using only their hands, which is great for someone who might have lower limb paralysis or impairment, like those living with spinal cord injury. And because this modality or equipment is so commonly used, it has also been frequently studied in research. In fact, the research has shown that arm cycling exercise can help reduce risk of cardiovascular disease. It can improve physical fitness as well as improve cognitive functioning. The next piece of equipment I want to talk about is called a recumbent stepper. And like the last piece of equipment, this one can be used from a seated position, which is great for someone who might have, let's say, balance issues. And what's really great about this equipment is it allows someone to move both their arms and legs during exercise while also offsetting any weakness they might experience. So for example, if someone has lower limb impairments, they can exercise using only their arms, but still get movement in their legs. And movement is key. And again, this is a piece of equipment that research has shown can help those with physical disability. In fact, one particular study demonstrated a 15% improvement in mobility for those recovering from stroke following an exercise program with this piece of equipment. Now, the last piece of equipment I want to talk about is one I find very interesting. It's called functional electrical stimulation cycling, or FES for short. And what's particularly interesting about this equipment is that it uses specialized stimulation to actually help the muscles contract and work harder during exercise. And while the stimulation is happening, there's a motor that passively moves the limbs of those using the machine. And what's great about this combination of stimulation and passive movement is it allows someone or anyone, regardless of their disability, to simulate exercise and get the benefits of exercise. Now, again, this is a piece of equipment that's amazing for someone who might have lower limb impairment, like those with spinal cord injury, or in the case of my research, people with advanced multiple sclerosis who use wheelchairs. In fact, I was very lucky to be part of a study that demonstrated improvements in strength and quality of life following an FES cycling exercise program for people with advanced MS. So these are just some examples of what exercise might look like, but I want to take a quick moment to recap what we've talked about so far. So it's clear from the research that exercise is beneficial for people with physical disabilities. It can improve mobility, increase physical fitness, and overall improve quality of life. And the research has also shown that exercise is safe for people with physical disability, and the benefits, again, far outweigh the risks. And as we've just seen, there are many different types of exercise equipment that can accommodate those with various types of physical disability. So what's the problem? Well, despite this, the most recent Statistics Canada report on disability and accessibility reported significantly less exercise engagement among those with physical disability compared to those without. Despite those with disability reporting a strong desire to engage in exercise. So what's stopping them? What's preventing people with physical disabilities from engaging in exercise? Well, unsurprisingly, the answer isn't black or white. There's a complex interplay of factors that contribute to exercise barriers for those with physical disabilities. One prominent barrier is outdated beliefs held by some healthcare practitioners. In fact, a survey conducted in 2021 found that current healthcare curriculums still perpetuate the idea that exercise isn't safe for those with physical disability, despite numerous research articles saying otherwise. And unfortunately, some of these teachings have been transferred to patients. And lastly, Even if a patient is highly motivated to exercise, there are still tremendous environmental barriers preventing them from doing so. In fact, a study conducted by researchers at McMaster University found that exercise centers that were deemed accessible still had major barriers from preventing those with physical disability from engaging in exercise, such as lack of adaptive equipment or just generally facilities that couldn't accommodate those with mobility impairment. So, where do we go from here? Well, as I said at the start of my talk, my goal was to have everyone here, or leave here rather, rethinking what exercise might look like to them. Because if we stop thinking about exercise as something that is just for able-bodied people and begin to rethink exercise as an activity for all people, regardless of their abilities, we can start to advocate for change. We can push for updated curriculum and education among healthcare providers. We can foster and promote self-confidence and self-efficacy among those with physical disability in their abilities to engage in exercise. And we can lobby for more accessible facilities that accommodate all people, regardless of their physical limitations. Because doing so will allow Canadians living with physical disability more opportunity to take control of their health and experience the benefits of exercise training. But again, it all starts with everyone here rethinking exercise. Thank you.
Now we welcome to the stage Dr. Andreas Kumar, a cardiologist and past chief of cardiology at Health Sciences North. He is an associate professor of medicine at the Northern Ontario School of Medicine University and the current president of the Canadian Society of Cardiovascular Magnetic Resonance Imaging. He recently founded a new cardiology clinic in Sudbury called the Neo Heart Clinic. Dr. Kumar will be presenting on a new view of heart attacks and the Canadian Cardiovascular Society classification of heart attacks. Welcome.
Thank you. 63,000 Canadians experience a heart attack every year. That's a big number. That's more than the population of North Bay every year. At the hospital right opposite of here, we treat 2 to 6 major heart attacks every day, and we treat between 5 and 20 minor heart attacks every day. We can count these numbers, we cannot measure the suffering that's associated with that. The heart is a muscle, it pumps blood, it sits in the center of the chest. It's an amazing machine, it pumps 100,000 times a day, and every minute it will push about 1.5 gallons of blood across the circulation to reach every little cell in your body. In order to do that, the heart itself needs oxygen and nutrients. Those nutrients get to the heart muscle via arteries that surround the heart, and you can think of this a little bit like a tree with a trunk, and water is transported to the leaves, which are the heart muscle cells that need the water to live. In a heart attack, one of these branches, a major branch, usually gets blocked with a blood clot. And suddenly there's a lack of oxygen, a lack of water flowing to that branch of the tree, and the leaves of the tree will now suffer, and eventually they can die. The heart muscle cells will suffer, and eventually they can die. What we do is we treat these patients as quickly as we can. We give them medication, we take them to the cath lab, we try to open up the vessel that is blocked in order to restore the blood flow. I started doing research into heart attacks about 20 years ago, and I started to read literature that was published in the 1970s. At that time, research was mostly done based on autopsy studies. So it was tissue that was analyzed and looked at under the microscope. What I saw is that tissue injury is actually much more complicated than just a blocked vessel and heart muscle cells that die. There are small vessels that get affected, and there can be a bleeding occurring into the heart muscle. We were not able to actually see that in our patients because we didn't have the tools. So about 15 years or so ago, I started to work on a method to make bleeding in the heart visible using magnetic resonance imaging. So I took an imaging method and I optimize it such that it would be specific for bleeding. We had a similar method for the brain already. We adopted it for the heart. We fine-tuned it. It was a lot of work, but at the end of the day, in 2011, we published a paper showing a way to make bleeding in the heart in the context of a heart attack actually visible in patients who are alive. So we no longer depended on autopsy studies, and we had actually a tool that we could use for our patients. Let me walk you through this and show you what we found. This is an image that I acquired in a research lab at 2 a.m. in 2010 in London, Ontario. I was using the research lab at night because during the day it was busy with patient studies and we would only get access to the instruments at night. These are 2 heart attacks, not from patients, but from an animal. On the left-hand side, you see the round tissue, which is the heart cut in a cross-section, and you see pale tissue from 12 o'clock to 4 o'clock. The pale tissue is dead heart muscle. This is an animal that had a major heart attack. In fact, it's about a third or so, or a quarter of the tissue that is affected here. On the right-hand side, you see another animal that had a similar heart attack, but here you see in the pale zone also a brick red zone in the center on the inner lining. That's a bleeding. That's a big bleed that happened into this heart muscle. And this was something that was not very well known and not understood at all. So when I was staring at this, I realized that this is actually something that's really big. This is really important. This could be something huge. So we went and we did studies with MRI. These are 2 hearts of patients who had a heart attack. You can see at the bottom of these images that the wall of the heart is moving really well. It's kicking blood and the valves are opening and closing. Where you see the arrows, there's an area of the heart muscle that's actually not moving. That's an area that has suffered a heart attack. It's just stopped working. These are other images here. You see a pretty good heart on the left, just pumping away. Now it's a cross-section. And on the image on the right, you can see that the area in the middle is actually not moving because the patient had a heart attack. There was a lot of research being done in 2000 to 2010, and we had more and more imaging methods to actually analyze the tissue. The imaging method on the left shows you with contrast a heart attack, and we were for the first time able to actually see it. This method was developed in the United States. It's a common imaging technique now. The black ring is healthy tissue. From 9 o'clock to 12 o'clock, you see white tissue. That is contrast, highlighting to us the heart muscle that has died. On the right-hand side, you see an image that is optimized using our method to visualize bleeding in the heart muscle. And we can see, this is the same patient, that inside of this heart attack tissue, there's actually a bleed going on. This method was very quickly adopted worldwide and became now the standard imaging method to visualize bleeding into the heart muscle. And a lot of research groups went on to study what this actually means. We learned a lot about this. We learned that bleeding occurs in about half of all patients that present with a heart attack. We learned that the bleed itself makes the heart attack bigger. There's an additional injury. We learned that patients who have a bleed into their heart muscle in the context of a heart attack, they have much more frequently heart failure. They will develop arrhythmias that other patients will not develop. We learned finally that these patients have a chance to survive, which is much slower, in fact, much lower than a patient who does not have a bleed. Patients who have a bleeding heart with a heart attack have a 4 to 6 times increase in risk of actually not making it through. We realized in the context of all of this that there's actually something else happening. It's not random who gets a bleed, who does not get a bleed. We learned with all of this that the injury actually evolves in 4 stages. At the first stage, when you block an artery only briefly, and you are able to open it up within an hour, so you diagnose the patient quickly, you treat the patient very fast, you're actually able to save almost all of it. Those patients will walk home, they will have a great life, they will be playing tennis 2 weeks after. If you go past that hour, the heart muscle cells will start to die. Importantly, the branches are actually still intact. This is the tree where you just block the water flow for a few hours, a few days. The leaves may turn a little bit pale, but once you provide blood flow again, or water again, they will actually recover completely. You'll end up with a beautiful tree. If you don't open up quickly enough, the leaves will die. At a third stage, you have an involvement of the small vessels, and the small vessels will get affected. At this time, the healing process will be much more difficult, because even if you restore blood flow, the small vessels will not be able to transport it. And the fourth stage is a complete destruction of the vessels, with bleeding happening once you actually open up the vessel. The small vessels are no longer able to contain the blood flow. They will rupture. You will have a bleed into the heart muscle. I realized this about 5 to 10 years ago, and we needed to do much more research to confirm this. Now, this I thought was important. Not all heart attacks are the same, but they actually involve in 4 stages. So we brought this idea to the Canadian Cardiovascular Society. I called the Canadian Cardiovascular Society about 2 years ago, and I said, I think we need to change the way we diagnose heart attacks. I think not all heart attacks are the same. I think there's a cascade of injury, 1, 2, 3, 4, and we need to put this out there. We need to change our diagnostic system for heart attacks. Now, when you call a big professional organization like the Canadian Cardiovascular Society and you tell them, hey, I want to change the way we diagnose heart attacks, that's a little bit like calling the Coca-Cola Corporation and telling them, hey, I want to change the recipe for Coca-Cola. It's just not going to happen. So they said no. But I persisted. And eventually they said, okay, good. So here's what you're going to do. You get us an expert panel, and we want all, or at least most of the leading researchers in heart attack on that expert panel. You write it all up, and you send it in, and maybe we'll have a look at it. So I did that. So I called my colleagues across the country, from the west to the east. I called some colleagues in the United States. I assembled an expert panel. And after a long, challenging review process, in January of this year, the Canadian Cardiovascular Society published the Canadian Cardiovascular Society classification of acute myocardial infarction, a new classification of heart attacks, a new view of heart attacks, a new way to understand this disease in 4 stages, the 4 stages that I just showed you. This was very quickly adopted. The moment it came out, the Europeans called it, and there was a paper in the European Heart Journal just about 6 or 8 weeks later. About 2 weeks ago, the American College of Cardiology published a paper on that in a journal called JACC Imaging. Another big paper is in preparation. We're really excited about this because heart attacks are no longer the same. We have a much more granular understanding of the disease now. We know that especially the bleeding is a very important event that occurs, and it opens up avenues for new therapies. If we simply understand that not all heart attacks are the same, then the consequences is that the optimal therapy probably also is not the same. We can apply this immediately to clinical care because we know a patient who ends up with a stage 1 heart attack is going to do really well. But if a patient has a stage 4, we must brace ourselves for possible complications. So what do we learn from all of this? There's 63,000 Canadians that suffer a heart attack every year. But I think we're getting better at this. We're getting a better understanding. There's thousands of research groups around the planet that are working on this 24/7. And I think with our contribution, we're opening the avenues for new therapies. So I think we'll be doing a better job for our patients a few years down the road with better therapies. The second thing that I think we learned from this is that Northern Ontario, Sudbury, Northern University is actually a pretty cool place to do really good work. So I'm really, honestly, I'm really, really grateful to be here and have all this support to do this great work. The third lesson that we learn is actually for you. What I showed you is that the severity of heart attacks progresses over time. The longer you wait, the more you progress down the stages of severity of a heart attack. So time is of essence. If you ever have a colleague, a friend, a family member, or just a stranger who looks at you and tells you, look, I'm not feeling so well, I get this chest pain, I get a tightness in my chest, and maybe it's radiating to the arm, but it doesn't have to. Or maybe it's radiating to the jaw, but it doesn't have to. If this is a pain that they can't explain, just call 911. Just give us a chance to sort it out. My team, the cardiologists at the hospital, we're ready to help. The nurses are ready to help. The paramedics, everybody is ready to help. Just make the call, because in a heart attack, Every minute counts. Thank you very much.
Welcome back, everyone. We will now be starting the second half of the show. Our next speaker is Patrick Bilek, a registered nurse at Health Sciences North in the Intensive Care Unit. He has been involved at the Northern Ontario School of Medicine University as a standardized patient and now as a tutor teaching medical students. He has now started his own first aid and CPR business, Vital Skills. Patrick will share with us how his unique experience as a patient shaped how he now approaches nursing. Welcome.
Every day, 27 Canadians are diagnosed with a brain tumor. October 9th, 2012, I was one of those 27 Canadians. There are no known causes for brain tumors, and they don't discriminate based on age, gender, ethnicity, or socioeconomic background. I was relieved to receive my diagnosis. Relieved because it had explained what had been going on in the past few months. My experience as a patient made me a better nurse. The brain controls quite a few vital functions, and the signs and symptoms of brain tumors can vary quite a bit. The most common will include blurred or double vision, weakness or paralysis, personality changes, frequent headaches, hearing impairment, dizziness and unsteadiness, nausea and vomiting, and seizures. Seizures are often what will lead to the diagnosis. I had two of the symptoms I just listed: vision loss and frequent headaches. However, these weren't the only symptoms I had. I found I could blame them on Kevin. Who's Kevin, you might ask? This is Kevin. Well, a plush representation of my brain tumor. Kevin was baptized by my dad 10 minutes after my diagnosis, so I could have someone to blame for my occasional odd behaviors, not always caused by the tumor. Kevin showed first sign of life around the time I graduated high school, and I received my diagnosis in my first semester of nursing school. Unlike this depiction of Kevin, brain tumors are invisible and often underestimated. Their signs and symptoms are often being dismissed until diagnosis. You would know that by looking at me, my skull has looked like this for the past 11 years as proof of the fight I've had. But this also means I can have really awesome pictures like this one. Kevin is a craniopharyngioma, or a benign, non-cancerous pituitary tumor, one of the 120 different types of brain tumors. The pituitary gland, not to be mistaken for a scrotum, is responsible for hormone production, from metabolism and energy level to the fight or flight response, and sexual and reproductive health hormones are essential to normal daily functioning. Kevin brought down the production of these hormones to near zero, which means having to take medications multiple times a day for the rest of my life. After months of unexplained symptoms, a clear head CT, and no physical causes to explain the loss in my left eye, the loss of vision in my left eye, I went to the emergency room and I had an amazing doctor. Dr. Stephanie took her time, listened to our concerns, and validated our feelings while performing a thorough assessment. Then scheduled the MRI for the next day. This MRI led to my diagnosis. However, The diagnosis was delivered by another doctor. He was efficient, but showed extremely poor bedside manners by telling me, "You have a brain tumor. I know it's shitty news, but I'm on the phone with 2 hospitals to see who's going to take care of you. Do you mind traveling?" The news in itself was shocking, but the delivery really took us by surprise. After the attention and the empathy from Dr. Stephanie, the contrast in behaviors was immense. We expected a greater, sensitive, and caring approach to delivering such difficult news. This moment defined the kind of nurse I am today and how I interact with my patients. In the next 5 months, 1 surgery turned into 3, followed by 7 weeks of radiation. I learned quite a few things as a patient. You've likely heard about hospital food not being that appetizing. Let me tell you, a diabetic muffin for someone who is not diabetic can really bring an 18-year-old's spirits down. Thankfully, Tim Horton came to the rescue more than once. I quickly noticed that resting in the hospital when you're ill is extremely difficult. There are nurses, annoying nurses, waking you up to take your vital signs and give you medication, equipment being moved around, staff talking at the nursing station, alarms of all kinds going off, from IV pumps to cardiac monitors, code alarms, not to mention the occasional scream of unknown origins. Silence is gold. Going through these experiences helped me develop an awareness of how staff behavior and various factors affect the experience of the patients I work with. It helped me develop empathy, making me a more attentive nurse. However, as a patient, a few things helped me cope. The day after my first surgery, Movember started. And as I couldn't grow a mustache, I turned my dressing into a mustache dressing. Humor, as you may have noticed, was present throughout my experiences. I also learned to rest whenever and however I could. Channel my inner Rocky Balboa to fight Kevin. Visualize the badass I wanted to be. And Hakuna Matata. No worries, as worrying means you'll suffer twice. I learned that you can never underestimate the impact you can have on someone. Like Shelley, who would bring me my meals, recognized me after my 3rd surgery. She saw me as a person, not as a patient. Or the radiation secretary. She was unbelievably kind and invested her time in talking with me and my parents. Seeing her put me at ease before my treatments. And Jazzy, a waitress at Cora. She made me laugh on a particularly gloomy day. She didn't know what me and my parents were going through, but still took the time to connect with us and still recognized us when we went back. I also had the ongoing support and listening ears of my friends who would come visit me sometimes and brighten up my day, or my radiation technicians, or my angels. They were caring, took the time to see how I was doing. Throughout my treatments, these check-ins really went a long way to make me feel heard and supported. Or my optometrist, Dr. Ekensviller. He was the first to ever mention the pituitary gland months before my diagnosis. Just by listening to my signs and symptoms, his instincts were not lying to him. Dealing with long-term effects of the tumor, the surgeries, the radiation, along with adapting to the new normal, is often challenging at the beginning, but it's really a lifelong process. Since the end of my treatments, I dove headfirst into the brain tumor community, connecting with fellow brain tumor warriors, patients, and caregivers from across Canada and leaning on them. Sharing our experiences brings a unique, relatable, and much needed support, creating bonds like no other. There are two people that were by my side from the very beginning, through thick and thin, and whose dedication, unwavering support, and love can't be summed up. My parents, Jean and Nancy Bedek. There's a quote I like from Harry Potter. Happiness can be found even in the darkest of times if one only remembers to turn on the light. My parents didn't only remember to turn on the light, they were the light. My experiences reinforce the importance of having a support network to lean on, and that humor can make dark moments a little easier. Without humor and social support, my outcomes would have been quite different. I want to leave you with this message. We can't control everything in life, and we don't know what the person next to us is going through. But being sensitive to their needs and having a caring approach can be the support they need right now to fight their versions of Kevin. Thank you.
We are now pleased to introduce Dr. Tara Leary, the Regional Medical Lead for Addiction Services at Health Sciences North. She will be helping us understand that there is more to behavior change than just willpower or willingness. In many cases, people lack survival necessities and community support, which makes behavior change hard. She hopes that we will understand how important compassion and understanding are for building a healthy community. Bienvenue.
Thank you. I'd like to invite you to build a tower with me tonight. Let's start with our fundamental biological needs. In order to survive, all living things must have access to shelter, food and water, restorative rest, and physical safety. When we have that squared away, we can move up the tower and start to work on building our community. That means different things to different people, but essentially it means we have a sense of belonging. Ideally, community includes access to healthcare, meaningful employment, support from family and friends, and belonging with groups and activities. Once we've built strong support from those first two layers, we can grow, learn, adapt, and look for fulfillment because we've reached the top of the tower. When someone at the top of the tower with all of these building blocks in place is diagnosed with something like diabetes, they have the capacity to manage it because they have tools and supports, or they can find those tools and supports. This can include access to primary care, benefits giving them paid time off work, as well as providing for things like counseling and benefits for physio. And yet, even here, at the top of the tower, people still have trouble changing, and we all make unhealthy choices from time to time. Some of us still smoke, some of us exceed the speed limit. So imagine how hard it might be to make healthy choices without these supports. What if you don't have family to get you to appointments? What if you can't afford medications or services like physio? It's harder to make changes when we feel alone. Now imagine that those changes have to do with using substances. The stigma around substance use further alienates us from supports, and the consequences of substance use can include loss of employment, income, and even housing. As the last blocks disappear, the top block has nothing left supporting it. There's more to behavior change than sheer willpower or simple willingness. Change is all the more difficult when people are lacking those foundational building blocks for survival needs and community connection. We mistake this for a lack of motivation, but we need to have compassion for people seeking to change their behavior. And to illustrate why this is particularly important for people who use substances, let's meet Will. So Will's based on people whom I've seen over the years, but he's not an actual patient. We'll say that Mr. Will Power is a 28-year-old electrician. He has a successful business here in Sudbury. He has a large group of friends whom he sees regularly, and he's paying off his mortgage. Will has all the building blocks in place for a solid tower. Let's say one day Will is injured at work and he receives a prescription for opiates after emergency surgery. Being a business owner, he has to go back to work before he's fully recovered, and he finds he's needing higher and higher doses of opioids to manage his pain. The opioids and the pain start to impact his work. So he has to close down his business, at least for a little while, because his performance is deteriorating. He just feels too unwell. This leads to losing his income and employment, not to mention some important social connections and his sense of purpose. Because he can't afford his opioid prescriptions anymore, he starts to drink instead to manage his pain and his withdrawal. He's ashamed of his drinking, of losing his job, and he can't afford to spend time with his friends anymore, and so he stops seeing them. Eventually, he can't make his mortgage payments, and so he loses his home. And with that, Will loses the ability to get a decent night's rest and to make a meal. Imagine as these losses add up, Will's foundation now looks like this. There's barely anything supporting his ability to survive, let alone his ability to make healthy choices. And yet, we expect that despite these losses, despite the shame and the guilt that he's feeling, he should just brush it off and get back to work. It takes confidence and motivation to seek the tools and the supports that we need to get better, to think that we can do it, that we're even worth doing it for. It's a long process, and it starts with those fundamental building blocks that we need for survival. We can't make someone else change. We can't make them eat more veggies or exercise more or stop using substances. But the way that we treat someone can make or break their ability to see that change is possible and that they're worth it. At this point in the story, Will's spending his time alone. He's alienated from family and friends. He's out of touch with work colleagues. Did you know that loneliness is as bad for our health as smoking 15 cigarettes a day? It independently increases our chance of dying by 26% and is a risk factor for developing things like cancer, heart disease, and stroke. Who do you share your goals with? Who do you share your fears with? It can be hard to share the things that we are struggling with and that we're ashamed about, but when that struggle is with an illness that already has so much stigma around it, it can be even harder. I challenge us all then to both treat and prevent this epidemic of substance use with compassion. Compassion for those who are struggling and may reach out to us for company or advice. Patience for people who are still trying to build their blocks or who are watching their blocks crumble away. Are we connecting often enough with friends and new neighbors? Are we team building at work? Are we volunteering? So loneliness is a real-time, current risk factor that can be addressed in the moment, but we've all come from somewhere. In our story, Will appeared as an independent adult, but he had a unique childhood, as do we all. As children, we reflexively react to our environment. With time, brain growth, and ideally some nurturing role models, we learn instead how to respond to our environment. And the difference between knee-jerk reflexive reaction and measured response lies in healthy emotional regulation. Best case scenario, as we're growing up, we learn to identify a wide range of positive and negative emotions. We learn to understand them, to be comfortable feeling them so that we can express them in a healthy way instead of bottling them up or blowing them up. Sometimes things get in the way of that process, though, and worst case scenario, we experience adverse childhood experiences, or ACEs. ACEs happen when our experiences stress our brain beyond its ability at whatever age to properly process what's going on. Research has shown that ACEs actually change the structure of our DNA. That's right, the genes down at the cellular level that tell our body what to do and when, not just regulate our emotions, but fight cancer, control our appetite, regulate our immunity. And so if we miss out on that opportunity to learn emotional regulation, not only do we miss a critical developmental window, but we also have fundamentally different DNA. And we carry those genetic changes and those coping skills into adulthood. Not surprisingly, the greater the number of ACEs that we experience, the more likely we are to struggle with substance use as a coping skill. The good news is, the same research has also shown that no fewer than 2 positive role models, adult role models, in a child's life will reduce the full impact of ACEs. Coming back to Will, it's entirely possible he had one or more of these experiences in his own life. It could be as common as being raised by a single parent who maybe worked really hard to make ends meet and was often gone. Maybe they couldn't afford rent a few times, and so he moved schools occasionally and didn't have a close group of friends as a result. Or it could be as traumatic as parents struggling with domestic violence and Will witnessing substance use as a child. Maybe he loses a parent to death or incarceration. The point is, we don't know someone's story. We have no idea in the moment that we meet what their journey to that point has been. And so I challenge us to both treat and prevent this epidemic of substance use with compassion. Compassion for those who are struggling and might respond to us in anger or frustration or withdrawal and silence. Can we lead with patience and open-mindedness, curiosity in our interactions instead of with fear and judgment? So remember that bottom layer of building blocks, the basic survival needs that form the foundation of this tower. Forget getting better. Just to get by, we need access to food, water, and shelter. In our story, Will lost his home. How do we expect him or anyone else to get better at anything when they have no warm, dry, and safe place to sleep at night? Lots of research has shown the mental, emotional, and physical impacts of sleep deprivation. Study subjects are usually the ones at the top of the tower, and yet even we struggle with lack of sleep. Imagine compounding that with illness or hunger. We can't put the time, effort, and energy into managing our diabetes or our high blood pressure or our substance use if we have to put that time, effort, and energy into finding a warm, dry, and safe place to sleep and a meal. And so I challenge us all then to both treat and prevent this epidemic of substance use with compassion. Compassion for people who are struggling, who we drive by every day. And I implore you to understand the complicated factors that lead to homelessness and the fundamental importance of having a safe place to shelter. How can we make healthy choices if we're alone, ashamed, possibly unhoused, when even people with all of the building blocks in place also struggle to make healthy choices? When we left off in our story, Will's foundation looked like this. But when we help people like Will, our friends, our neighbors, our coworkers, our family, we can help them rebuild their blocks. And that's the amazing thing. We don't have to do it for them. With compassion, they can rekindle and build the tools that they need to do it themselves. Many community agencies exist to help people along the continuum of substance use. They can be difficult to access. And the system is fragmented. These are system-level issues that we may feel powerless to address, but I have seen people do amazing things when they feel supported, when they feel they belong to something, they feel valued and heard. Very few people stand in a pile of blocks with the tools and the confidence to think that they can build a solid tower. Compassion won't build it for them. But compassion will give someone the confidence to take the first step And that is how the journey to the top begins. Thank you.
Next, we will hear from Dr. Pablo Cano, a rheumatologist, oncologist, and associate medical professor at Northern Ontario School of Medicine University. With decades of experience treating patients in Northern Ontario, he has led the way in administering innovative treatments for autoimmune diseases and cancer. Dr. Cano will help us understand how the immune system works, what happens when it goes wrong, and how medical treatment has advanced to treat disease by targeting the immune response. Welcome.
Thank you. Well, healthy joints allow us to move. They make it possible for us to walk to work, to enjoy exercise, to look after the baby. So normal life really requires that our joints, bones, and muscles work properly. Now, simply put, arthritis damages joints. That's actually the essence of arthritis. And the most common type of arthritis is called osteoarthritis, which is caused by wear and tear. And eventually, it tends to occur with age, or in people who have certain occupations, or if they've had previous trauma, previous injuries. Quite often, osteoarthritis does not even need to be treated with medication. Simply be careful, protect your joints. However, in a number of cases, the arthritis can be severely destructive, leading, for instance, to the need for a joint replacement, particularly hips and knees that are the most commonly affected, but will affect just a few joints. Rheumatoid arthritis, on the other hand, is quite different. Rheumatoid arthritis can cause major damage in multiple joints at once, and it may move on very fast. In 6 months, it can cause a crippling and severe deformity that may be irreversible at that point if the arthritis is not caught on time or if it's not treated properly. And rheumatoid arthritis is caused by our own immune system. See, normally the immune system is our protector, our main defense mechanism. However, something happened with rheumatoid arthritis. The immune system, rather than protecting us against the bacteria or bugs, suddenly starts attacking our own joints, our own bones, our own organs. Something had happened with the immune system. This is what they call autoimmune disease, or self-inflicted autoimmune disease. Now, where is the immune system? What is the location of the immune system? Well, the immune system is located in different organs of the body, key organs, and also in the circulation. They are flowing throughout the body, so surveilling the system to make sure that nothing happens. Now, the immune system is a very complex, very imaginative system that can be compared really to a military system, to a very, very powerful army with all the elements that we are accustomed to see, from the chiefs, from the supervisors, to the front line soldiers. So the main locations are what we could call the headquarters, the bone marrow, where most of the immune cells are produced, and then they jump into the circulation. Then lymph glands, where are inhabited by a lot of immune cells. The word lymphocytes comes from lymph gland. Then the thymus, which is an organ in the front of the chest that actually helps to mature some of these cells. There are also some what we could call remote stations, places that are located far away from the bone marrow, but where there's also immune cells ready to act if there is any local problem. You have, for instance, the liver, the spleen, the tonsils, and an organ that is very important, is growing in importance now, the bowel. So the cells of the immune system perform different roles. There are dozens of different types of cells and categories of cells. Some of them are very sophisticated. You know, they have the ability to identify where the infection is, They have the ability to send proper cells to control that infection. So keeping up with that army metaphor, we have the senior military officers, the generals, the captains that decide where to attack, how massively to attack, or perhaps the attack should be controlled because the threat is not that big. So besides them, we have the guardians and the sentinels. They are the ones that do the initial call. They sound the alarm. There is an infection here, there is an attack here, and they actually send messages. They are, of course, not electronic emails, or however, the messaging that allows immune cells to actually converse between each other. They're called cytokines. They are chemicals that are actually produced by different white cells and that allow them to coordinate the attack. Some of them will actually send the cells to the right place. Some of them will actually increase or decrease the magnitude of the attack. Because, if you are attacked by a very small infection, it would not be wise to jump to a massive infection. If you're trying to kill a fly, so you're not going to use a bazooka to kill it because then you'll destroy your home at the same time. So then at the bottom you have the first responders, the ambulance. Actually, in this case, the first responders are the front line cells of attack. The white cells that actually, in the general term, is macrophages and normal white cells that jump initially to control the infection. And that after all this is done, or while it is done, the immune system has to make sure that it does not cause collateral damage to our own organs, because that will be harmful. And that's why the immune system has what is called the immune memory. The memory is actually a system by which our own cells, since childhood, even since before we're born, register the normal structure in our body. They encode what's normal DNA so that never in the future will they start attacking our own body. What happens with rheumatoid arthritis, unfortunately, is that something fails there. And the immune system is starting to look at your own bones like an enemy and start attacking it. So lymphocytes, they are probably the most sophisticated cells of the immune system because they have significant functions. They can attack immediately, or they can have what they call adaptive function. They can produce antibodies slowly that will ensure that you have permanent immunity. The T cells help to regulate that immune response, those T lymphocytes. There's what they call helper cells that will enhance or push the cells to attack more vigorously. There are also regulatory cells that will tell them to hold off, reduce the attack. Then you have cytotoxic cells, which are the ones that destroy cells. They are the kind of immunity against cancer. If the body identifies cancer, they will attack it to try to destroy it. The B cells, on the other hand, are the ones that produce antibodies. If we keep up with our military metaphor, the B cells will be the weapons factory. They will manufacture antibodies that are very specific, and they are actually produced to attack specific target that we call antigen. When the antigen shows up, the B cell will produce an antibody that will be very specific, and for instance, when you get a vaccine, the message would be messenger RNA will get there, and they will enable the cell to produce the right antibody for that target, so that when that bug reappears, or COVID in this case, the body will be ready to counteract it. So what causes rheumatoid arthritis is this autoimmunity, the fact that the immune system is malfunctioning, attacking our own body. It will cause joint swelling, as you see, multiple deformities. This area of the hands, but sometimes it'll attack simultaneously. Both hands, a knee, a shoulder, an elbow, and so on. So a normal joint, as you see here, is this structure is, see the sac, it's called the synovial membrane. The cartilage, which is sort of the cushion between bones, so that the bones will not be rubbing on each other, wearing out. and fluid that lubricates the joint. When the joints affect rheumatoid arthritis, then the inflammation, the immune attack will lead to erosion, breakdown of the bone, damage of the membrane. The cartilage will be destroyed, be painful, the joint will be swollen. This is what leads to the deformities. And luckily, at present, the treatment for rheumatoid arthritis has been enriched by a number of discoveries. Whereas 50 years ago, when I first came here, we only had aspirin, cortisone, not much more. Nowadays, we have a few dozens of new drugs, some of which are really very effective because they tend to block many of those cytokines that tend to mediate the immune attack against the joint. So they can prevent a lot of the damage. The key, of course, is to act promptly. Normally, as soon as the diagnosis is made, anti-inflammatories, physiotherapy, and a series of drugs that may consist of 2 or 3 simple drugs may control it, but in some cases it is more severe than the more active drugs, such as what's called biologicals or antibodies, would do the job, and they can give a much better life for patients with rheumatoid arthritis. So the last diagram actually shows the bugs that inhabit our gut. Actually, our gut is inhabited by trillions of bugs, bacteria of different kinds. You've heard about the story about good bacteria, bad bacteria. And now the microbiome, which is that family of bacteria, is associated with either better health or with poorer health. Rheumatoid arthritis is subject to considerable research, and research in Sudbury has been already started with studies of microbiome. It's the combined efforts of the medical school and the hospital research institute. And it's very promising because hopefully this can allow us to prevent the disease as much as possible and will make it less necessary to engage on this very powerful drug that may have all kinds of side effects. Okay? So the microbiome research is the last addition, in addition to immunology, to X-ray, and everything else, to control rheumatoid arthritis. Very promising. Thank you. Okay.
Our next speaker is Dr. Nana Juma, an obstetrician-gynecologist at the Thunder Bay Regional Health Sciences Centre and a researcher at the Northern Ontario School of Medicine University. The stigma of substance use in pregnancy can affect the quality of care received by marginalized women. Dr. Juma will share how her work in Indigenous, rural, and remote women's healthcare informs how she cares for her patients and sheds light on the biases these women face. Bienvenue.
I want to start with a quote. At no time in a woman's life is her identity more obviously socially supervised and regulated than during pregnancy. Pregnancy as a physical stigma. This has many positive attributes, and we see that oftentimes in images in popular media, where we see these warm-hued tones, women embracing their children in idyllic locations. But this good mother mystique also has other things associated with it. Women are expected to be selfless. They're expected to put their children first. There are impacts on what people think we should eat while we're pregnant, the activities we should engage in, and how we should behave. And that's why images like these are very difficult for us to understand. And the idea of the good mother mystique is challenged when we see Snooki Polisi, who is a social media star who posted this image on her Instagram. This image received universal backlash in the media. But let's unpack what bothered people so much about this image. What do we know about alcohol in pregnancy? We know that alcohol causes changes in growth, development, and behavior. There's no safe amount of alcohol in pregnancy, and no alcohol in pregnancy and while breastfeeding is safest for baby. We also know that the impact of fetal alcohol spectrum disorder is quite large. So FASD impacts about 4% of Canadians. That's more than autism spectrum disorder, cerebral palsy, and Down syndrome combined. 90% of individuals with FASD also have mental health issues, and the social and economic impact of FASD is approximately $1.8 billion per year in Canada. And yet, this mommy wine culture is everywhere. And this really came to my attention when I saw an ad in my local community for a Babies and Brews. It's a baby-friendly initiative by a local restaurant to promote a time where breastfeeding people can enjoy a beer with other new parents. If we're promoting breastfeeding and alcohol, is it really baby-friendly? How come this mommy wine culture is so normalized in our society? So let's take a closer look at this image on the left. The image shows a white woman holding a baby with one hand and a glass of alcohol with the other. She looks happy. They're cues to let us know that she's older, she has some wrinkles on her forehead, and probably wealthy. The baby looks directly at us. The baby's wearing pearls and lace. The alcohol is champagne. Now let's go back to this image of Snooki. She's a Latina woman holding a baby with one hand, a glass of alcohol with the other. She looks young, and there are cues to let us know that she's probably from a lower socioeconomic class. She has a top ponytail, visible bra straps. The baby is listless and appears not engaged with the mother. So why is the image on the left celebrated and the image on the right scorned? On the surface, both images are the same. So I want to unpack why that is. Could this person drink alcohol while pregnant? What about this person? And this person? Who is allowed to drink alcohol in pregnancy? What do pregnant people understand about drinking alcohol? From a societal perspective, if you're poor, Indigenous, a person of color, your baby could be taken away from you if you're seen drinking alcohol in pregnancy or while breastfeeding. If you're white, middle, or upper class, you can drink in public while pregnant or breastfeeding your baby. That is the definition of stigma. And stigma has many facets, starting with labeling a group, attributing negative traits to that group, identifying that group as other, and that leads to discrimination and oppression of that group by the group that feels that they are in the right. Stigma doesn't just exist with alcohol use in pregnancy, but with other substances, including opioids, as well as with mental health concerns. And this fear of judgment makes people reluctant to seek care. When they do seek care, it's a barrier to treatment. And particularly with substances, people are often perceived as drug-seeking if they go to care. Stigma has consequences. Statistically, we see that more Indigenous and Black children are being taken from their parents and placed into care than the percentage of the population that they represent in Ontario. And this isn't a reflection of bad parenting, it's a reflection of our societal stigma against people we see as other, and we attribute these negative ideas onto. So what are we supposed to do as healthcare providers? I'm supposed to ask all people about substance use and mental health issues, provide a brief intervention for these issues, create space during an appointment to talk about substance use, to talk about mental health, and to make specialized community-based interventions accessible to people with substance use, social concerns, and mental health concerns. It's all very clinical, but it doesn't really address the root cause of all of these issues. So I want to talk to you about trauma. Trauma is when we have encountered an out-of-control, frightening experience that has disconnected us from all sense of resourcefulness or safety or coping or love. And we hear that word thrown around a lot, but I'm going to give you some examples of what trauma means. And I'm going to use this tree metaphor. When you see someone who's visibly struggling with addiction or mental health issues, what we see are the branches of the tree. And they're often stunted, wilting leaves. And these are the negative behaviors, the fractured relationships, the decline in physical appearance that we see. But what we don't see are the roots of the tree. And the roots represent the trauma that impacts what we see above ground. And the soil represents society and our role in supporting healing and growth from trauma. In order to have a healthy tree, we must have healthy roots, and we must have a healthy society. So trauma can happen to people from all walks of life. There's a very prominent case, Senator Romeo Dallaire, who was a head of the UN response to genocide in Rwanda, who had a very public car crash on Capitol Hill as a result of ongoing PTSD from his experience. Communities can be traumatized when events affect the members, such as in Lac-Mégantic when there was a horrific train crash, resulting fire, loss of the community, and many deaths. Nations can be traumatized when there's a coordinated attack on a national identity and values, such as the September 11th attacks on the World Trade Center in the US. And cultures can be traumatized when repeated denigration attempts at assimilation and genocide occur, and this can happen over generations, such as colonization in Canada and its resultant structures such as the residential school system. So trauma-informed care addresses these root causes. It tends to the roots of the tree first before trying to address the branches. So how do I approach patient care? I just assume that every person in my practice has experienced trauma. I recognize that there's a power imbalance between me and the patient who's sitting in front of me. I make the distinction about who the patient is as a person, as a human being, and what has happened to them. And I work from a resilience-minded perspective that helps people who've experienced trauma realize that they have the skills to heal and grow. And what can you do about this? You can practice critical self-reflection. Examine your own life experiences, your biases, and how they influence your opinion of the person who's in front of you. Practice radical empathy. When you encounter someone who's asking for money, who's sleeping on the street, reflect on what may have led that person to be in that particular situation. Look beyond the drugs, the mental health issues, and remember our shared humanity. Treat the person with kindness and in a manner that affirms their dignity. So I'm going to tell you a story to let you know why this is important to me and why I think it should be important to all of you. I'm going to tell you a story about a teen mom with 2 kids. She was a victim of abuse throughout her whole life. She suffered from mental health concerns and eventually was diagnosed with schizophrenia and later struggled with alcohol use. Her kids were in and out of care, and eventually they were apprehended. In her sorrow, she still hoped for better for her children. Over the years, her kids benefited from acts of radical empathy and were shown the kindness and afforded the dignity that she never received. And that is why one of her children is standing before you today and asking you to look beyond the branches of the trees with their wilting leaves and take time to nurture the roots. You never know what may grow. Thank you.
Our final speaker for this evening is Alicia Grace Chenier, a Cambrian College graduate now pursuing a degree in disability studies at Toronto Metropolitan University. At a very young age, Alicia lost most of her vision because of a brain tumor, but that never stopped her. As a disability advocate, she lives her life to raise awareness and create a change in this world. She will be sharing her personal history with white canes and hopes to show us that they are not only a way forward for mobility, but also for self-expression and empowerment. Welcome.
At the age of 6 months old, my mom would find out I had a childhood brain tumor that would cause permanent blindness in my left eye and only leave me with tunnel vision in my right eye. I would grow up needing extra supports in my life, and one of those being a mobility device called a white cane. A white cane is an object detector. What that means is that while a blind person walks, they swipe the cane in a back and forth motion in front of them while moving to detect any and all items or barriers in their way. Today, I will be talking about my journey with my white cane. This is the story of how I overcame society's perceptions and started using my white cane for not only access to independence, but for empowerment and self-expression. I chose to hide my disability for years because of the society's perception for how the white cane was perceived. At this time, it was the early 2000s. Disability wasn't something that was talked about. It was known I was blind in school, but besides accommodations my teachers would give me, my disability wasn't even acknowledged. People at this time were too scared to talk about disability, so naturally I hid because of that. And never took my white cane out. It wasn't until later in my life that I would be going out more and getting more and more independence that I would even look at my white cane. Here I am at 9 years old, after my orientation and mobility instructor gave me my first white cane. Orientation and mobility instructors are instructors who teach blind people how to use white canes and navigate the world of blindness. As you can see by my face, I was absolutely miserable with it. I already knew I wasn't going to use it, and it would only come out of my backpack once a week when I would have white cane lessons. To me, at this point in my life, I was already getting bullied daily for being blind, and so the thought of having a visual reminder for people to know I was blind was terrifying. I didn't want to go through more days of school being tripped on by the other students or being asked by one of my bullies, "If I stabbed you in your blind eye, would it hurt?" I was scared to be blind. And so instead, I hid away for years, not wanting my white cane because of the perceptions my peers around me had about blindness. The day of this photo specifically, my mom decided we should go on a trail walk to try out my new white cane. I always hated trails because I would trip on branches or random parts of the trail I wasn't able to see. This day, while walking the path with my white cane, was a way for me not to trip on the trail. But while on the trail, all I could think about was being labeled as the blind girl, the girl who got extra help in school and needed extra large papers, the girl who had a disability. Let's just say this was the only time I had ever used my white cane in a public space for a very long time. At the age of 19, shortly before starting college, me and my orientation and mobility instructor were doing another lesson of learning bus routes to get to my college that I would soon be attending. My instructor had asked me if I'd be willing to try using my white cane again. College would be different, and I wouldn't be bullied like elementary school. She told me college was going to be a big and busy place. I thought about it, but the thought of using my white cane, this tool I had only seen as a symbol of being pitied and bullied, she then asked me if I would be interested in a pink white cane. Now, that definitely piqued my interest. Pink was, and obviously still is, my favorite color. It was a way to personalize it, and this option felt like something that was defying the odds and perceptions of society. A few weeks later, I got my new white cane and was getting ready to go on my first big trip alone. I got accepted into a program for blind youth across Canada going into post-secondary school to teach me everything I needed to know. When I got there, I did use my white cane at the airport, but then put it away quickly after. The thought of using my white cane, I was nervous to use it. One of the people leading the camp noticed I wasn't using my white cane and proceeded to ask me, well, where is it? I told them it was put away and I was still getting used to it. However, I was still nervous about what society would think about me. It wasn't until that moment when the person had said, your safety is so much more than what people think. And that was the moment the perception of my white cane changed. A few more impactful moments from this trip was the time I met my best friend, Emily, the one who truly got me comfortable with my white cane. She had seen my white cane folded up on my desk and seen it was pink. And at that time, this wasn't something that was often seen to have different colored canes. She expressed how cool it was that I should really be showing that off. Then there was a time two of my friends and me were using our white canes as we were walking together and in unison, had our white canes in syncs. 3 of us walking as if we were in some sort of marching band. I came home a new person and had gained confidence myself as a white cane user, something my family had never seen before. Oh, and remember how I didn't like walking trails? I came back from that trip and walked the same trail, only to succeed this time and making it to the top of the view. Since then, I have gotten many different white canes and have discovered an entirely new side to the mobility device. Yes, while it is a tool for safety and independence, my white canes are so much more than that. I'm a girl who loves fashion and have found a way to incorporate my canes within my fashion and self-expression. I have gotten white canes for events like the Taylor Swift concert movie, where I got an entire cane covered with rhinestones on it. This cane gave me so much confidence, and so many people were saying how cool it was. At Christmas time, I was asked to be a part of the Christmas parade, so naturally, I made a candy cane. I even put twinkle lights on it so that everyone could see the fun design on it. I have had many different colored white canes. I've had a blue one made for when I went to see the Blue Man Group. I've had a gold one for more fancier events. I even just got a new cane made for when I go see the Taylor Swift concert in a few months. And last but not least, my favorite cane, my pink cane. I even gave it a name, Seymour. Why, you may ask? Because at 19 years old, I thought it was comical to name it Seymour, as technically, it does see more of the world than I do. This white cane has so many memories for me. I used it when I went to see the Barbie movie, and I played the role of blind Barbie. I like to call this photo the one where she is blind and confident. And this was the white cane I graduated with in college, something that no one thought I was ever going to be able to achieve. Today, I am a college graduate and now in disability studies, getting my bachelor's degree. I'm also a motivational speaker and a disability advocate for youth across Canada with vision loss. My goal in life is to share my story and break down the stigmas and barriers I had as a child. No blind child or youth should ever have to hide who they are. My hope is that we'll be a future where disability will be more normalized within society, and all people with disabilities can live confidently and proudly. So, from now on, I encourage each and every one of you to see blindness and disability in a new light. Understand that blindness is a spectrum, and no two blind people see the same way. Blindness at any age, no matter when diagnosed, can have major effects on a person, whether that be physically, mentally, or emotionally. And most importantly from today, know what a white cane is, and understand that the journey that the white cane user has gone through to be the person they are today. Over my lifetime, I have learned my white cane can be a tool for independence, but also self-expression and empowerment. Thank you.
Okay, if anybody else needs a break, just to take a little tear, to have a little laugh, I think we had quite the journey tonight. I want to thank again all of our incredible speakers for sharing your time. I mean, they're incredible. They put so much work into this, and we are so grateful that you were willing to be brave and share your stories. I learned a lot myself. First of all, I was telling somebody over the break, I never knew that you actually stopped breathing when you were under general anesthesia. I don't know why I didn't think of that, but oh, see, I wasn't the only one. No, exactly. I think, we learned a lot I always am amazed at Northern Ontario and the type of medical fields that we have here and the expertise here in Northern Ontario, the things that we can discover, and the people, of course, that we serve with our health connections. It always amazes me. So thank you so much. And I'm really excited to remind you that all of our presentations are going to be available on YouTube. We're streaming live there tonight. And thank you again to Eastlink for helping us do that. And you can listen to these again. And be sure, share them widely. We want people to learn and understand more. So please do that. Put it on your social, do whatever, but send it off to family and friends and people so we can all learn from this amazing event tonight. Your feedback is very important to us. So please take a few minutes. You can scan our QR code and fill in evaluation for tonight's survey, for tonight's event, a survey for tonight's event. And we're gonna end tonight with a social right here in the Valet Cavern, and we're really looking forward to chatting with each and every one of you, and our presenters some of them are going to stick around, so you'll be able to chat with them tonight. And to our audiences across Northern Ontario and Canada, thank you for joining us. Chimigwich, merci, merci. Thank you very, very much. Have a great evening.